I know it's always very challenging to present after a heavy lunch, particularly talking about a population that is already left behind. So I'll try my best, to make sure that you stay awake, and I'll try to make it as interesting as possible. So I would like to thank the organizers of Interest 2019 for the opportunity to stand before you and to talk about an issue that is very, very personal to my heart, and to share with you some of the experiences we've gathered over the years, over the past 4 or 5 years, implementing programs for key populations across multiple countries in Asia, Latin America, and the Caribbean, and of course in Africa. So I'm going to be talking about the progress that we've made over the past couple of years, engaging key populations in particular in the fight against the HIV epidemic. I have no conflict of interest, nothing to disclose. I'm going to talk very briefly about HIV among key populations in Africa, and then provide an overview of the Linkages Project, and then some opportunities that we currently have to engage key populations as we continue to fight against the HIV epidemic. And of course, share a few examples from some of the African countries where we're currently implementing the program. Of course, we're all aware, and I thank you very much for the presentation that we'll listen to in the morning, particularly around Ghana, and the contributions of the various key populations to the HIV epidemic in Ghana. We're all aware that key populations are at greatest risk of acquiring HIV, at the same time transmitting HIV to their partners. According to the latest UNAIDS data, we know that at the end of 2017, about 16% of new infections, particularly in Eastern and Southern Africa, were from individuals who are within the key population community. We're talking mainly around men who have sex with men, female sex workers, transgender individuals, and people who inject drugs. Now, again, from UNAIDS, you will see from your far right, in terms of global contributions, you see the various contributions of key populations to the HIV epidemic in terms of new infections at the end of 2017. The one in the center or in the middle is actually around West Africa, and of course, East and Southern Africa on your far right. Again, to give you an idea of the contributions of the various key population groups, talking specifically around same-sex practices, contribution of men who have sex with men to the HIV epidemic among various countries in Africa. And this is mainly from mode of transmission studies across multiple countries. And you see that this varies from country to country. But showing you that in some countries, almost 25% of the new infections you're having are actually from these key population groups, particularly men who have sex with men. And talking about the female sex workers, or talking about talking about sex work. Now we're talking about sex work, not specifically female sex workers, because there are a lot of individuals who are engaging in transactional sex who don't consider themselves to be sex workers, but they keep transmitting the infection. So you see that as well, but not just sex work, but contributions from the clients of these sex workers. And I think this is very, very important. As we continue to engage key populations, we also think about their clients. We also think about their partners. And I think the opportunity presented by index testing now actually gives us a very good leverage in terms of being able to reach not just sex workers, but also their sexual partners, as well as their regular partners. Now, a little bit about Linkages Project. The Linkages Project is PEPFAR's first global project dedicated purely to key populations. It's a service delivery project. So I'm not sharing, what I'm going to be sharing today, I'm not sharing data from research, I'm sharing data directly from program implementation. It's led by FHI 360, and we have 3 other strategic partners, PACT, UNC in North Carolina, and Intro Health. We have worked in over 35 countries across Africa, Asia, and Latin America and the Caribbean. And of the over 160 sub-awards that we currently have, and of the 72 sub-awards that we have in Africa, 29 of them have been to key population-led organizations. So these are organizations that under normal condition wouldn't qualify to receive funding directly from US government, but we're subbing them, and they are now part of full implementation of programs providing services to key populations across the entire Cascade. I'm going to show you some results. The goal of the project is to accelerate the ability of government, key population organizations, the private sector, in terms of fighting against HIV among 4 key population groups: MSM, sex workers, both male and female sex workers, transgender individuals, and people who inject drugs, with 3 main result areas. The first one is to improve access to services. Number 2, also increase demand for the services. And number 3, to build systems, particularly M&E systems, and to support government to be at the forefront of the fight against HIV, particularly among these key population groups. Now, giving you an idea of the various partners that we have across the globe, Linkages has a global advisory board that's, members from all over the world, from donors, from funding agencies, from global networks of key population groups across the world. And just give you an idea, and I think this board has actually helped Linkages to have a good inroad into countries, because a lot of the key population-led organizations in most countries are members of these global networks. And now, giving you an idea of the various countries where we have implemented or where we're currently implementing, about 15 countries across Africa, a few in West Africa, and of course, the majority of them are in Eastern and Southern African countries. Now, when we talk about engaging key populations, we're talking about so many things. It's a wide spectrum. So we're talking about ensuring that key populations are actively involved in the design, in the implementation, in the monitoring of key population programs. And it's not just taking services to key populations, but actually letting them sit at the table with programmers, with implementers to design the program so that the programs actually meet their specific needs. Everything that Linkages is implementing currently is across the Cascade, and this is what we call the Bible of Linkages. And we always joke among ourselves, if you're going for any conference, if you're traveling to anywhere, if you're doing anything at all, what part of the Cascade would this help address? So you can see from prevention, from identifying key populations, to reaching them with services, to linking them to testing, and then moving those who are HIV positive across the right side of the Cascade, and of course those who are negative, ensuring they have constant access to prevention services, including PrEP, where available. Now, various service delivery models. And you can see that we have community-based services, and a lot of our treatment and care support services are within public facilities, or what we call hybrid facilities. And of course, we also have some community-based spaces that are considered to be safe spaces for key populations, like drop-in centers or one-stop shop where services are provided for key populations. Now, you're all aware of the various challenges that we have across the Cascade. The first one is reaching the right population with prevention services and ensuring they are linked to testing. The second one is ensuring that people who are reached are tested, but not just testing everybody, but testing those who are considered to be at high risk of HIV. Number 3 is ensuring prompt linkage to care and treatment among those who test positive. Number 4, prompt ART initiation. Number 5, viral suppression. But I think to us as Linkages, the most important challenge that we're having right now is actually tracking key populations across the entire continuum, tracking them from prevention to care and treatment, keeping in mind the fact that treatment is generally available within public facilities where a lot of the key pops are not comfortable accessing treatment and care. Some of our interventions, I'm going to skip this, but just give you an idea of a barrage of interventions that we have across the Cascade. All the services that are provided to key populations are currently being delivered at scale, at standard, and at speed. Despite the fact that we're implementing across multiple countries, we're trying to standardize our approach and ensuring that all bottlenecks, particularly when providing TA, are addressed speedily. Again, keeping in mind that everything you're doing, you need to ensure that your client is at the center of it. Ensuring key population individuals are fully engaged, they're at the center, and we're trying to meet the needs of each key population individuals. Various service delivery modalities. The most important to us, again, number 1, drop-in centers. How do we make sure that key populations are able to access the services that they need in centers, in spaces that are safe for them, not necessarily in public facilities, wherever they are, but ensuring that they are safe, We also provide services through outreach clinics, through mobile clinics, hybrid facilities. So some public facilities actually have dedicated spaces for keep ups, and of course we have static clinics that are funded and supported directly by linkages. So what are some of the opportunities for engaging keep ups as we fight against the epidemic and towards achieving epidemic control? Now, I want you to take note of some of the PEPFAR priorities. Now, I'm making reference to PEPFAR because we're a PEPFAR implementing program. Number one is ensuring access, test, and start. So all policies at country level must be in place. Evidence of resource commitment by governments, by various countries. Ensuring key populations also have access to multi-month scripting, not just scripting, but also dispensing. Ensuring they are part of TLD transition, and making HIV self-testing available where it is not currently available. Making sure that individuals who are HIV positive, who are not having TB, have access to TB prevention therapy. Ensuring that we strengthen unique identifier codes to be able to help address the challenge I highlighted earlier in terms of tracking keep-ups across the entire cascade. Institutionalizing index testing. I'm going to talk more about that, and of course, monitoring across the cascade. Some examples of some of the approaches that we're currently using across multiple countries to reach key populations. Now, if you look at this slide, I titled it a paradigm shift, because gone are those days when we used to think that CSOs, KP-led organizations are only involved in prevention. They're only involved in SBCC messaging. They're only involved in community mobilization. They are now involved in service provision across the entire continuum, from prevention to testing, to linkage to ART provision, particularly in community spaces, to viral load testing, access to viral load testing, and of course, some structural interventions I'm going to make reference to. Now, for the first 90, we have an approach that is known as the Enhanced Peer Outreach Approach. This is a social network strategy that helps to empower key population individuals themselves to mobilize individuals within their networks to come forward for services. We're fighting across multiple countries to increase case finding, to increase what people call yield, to ensure that individuals who are not yet known or who don't know their HIV positive status, know their status. So we need some innovations to be able to go across multiple countries, to be able to go across multiple hotspots and reach KPs who will not be found at hotspots traditionally. So the EPOA, or the Enhanced Peer Outreach Approach, is something that we've used. What does it entail? It entails a peer outreach worker who is a trained volunteer who receives one stipend or the other to identify individuals who are KPs, who are self-motivated, who have large networks that have not been reached with HIV prevention services, and ensure that these individuals are mobilized to come for services. What are we seeing across multiple countries? Example from Angola. Now, those those circles in red are individuals who are HIV positive. Same thing under Botswana. We're beginning to find situations whereby individuals who have never been reached with HIV testing services through outreaches or through mobiles are now being reached using this approach. We're finding very high case finding rates across multiple countries. Not just increase in case finding, but ensuring that these individuals who test positive are linked to treatment. So we're also seeing high linkage rates, high ART initiation rates across multiple countries. Example from Cote d'Ivoire, which is just close by. If you look at it in FY17 Q4, that was the first time we actually introduced EPOA. And the case finding increased from about 3.2% in Q3 of FY17 to 21.4% in Q1 of FY18. Again, we introduced EPOA and now incorporated EPOA with index testing at in Q3 of FY18. Case finding also increased to about 13.1%. So what are we doing now? We're trying to ensure that some of the lessons learned from implementation of EPOA are fully integrated into routine programming so we can actually sustain the benefits that we're getting from EPOA. Again, in Cote d'Ivoire, among MSM, we're seeing the same thing. Each time EPOA was introduced or was implemented, we're finding very high case finding. Now, what is important here is that a lot of the individuals who mobilize people to come for testing are key population members themselves. So I think engaging key populations at every level is key to achieving that first 90. Now, I'm going to talk about something that is very, very special to us, and this is something that may be new to a lot of people. But if you look at what we're preaching right now, we're talking about test and treat, which means test as many people as you can test and make sure that whoever tests positive is initiated on treatment irrespective of CD4 count or viral load. Now, we know a lot of countries are about reaching the first 90. So we have very few people that are left that are yet to be tested. If we continue using the current approaches, we'll have to test as many people as possible to find very, very few cases. What does that mean? We probably need to look at how to change the approach. How do we treat and test? What does that mean? How do we engage PLHIVs, keeping in mind that whoever is HIV positive definitely has somebody somewhere who he or she contracted the HIV from, or who he or she has passed the HIV to. So we need to focus more of ensuring that we provide the needed support to PLHIVs, and then doing that, they can link us to individuals who need to be tested. Using that approach, we can focus more, test less people, and then find a few cases of HIV positive individuals. So what are we doing? We're looking at test, or we're looking at treat and test using two approaches. The first one is the traditional index testing, which is asking people to elicit their contacts, elicit their partners, and getting them tested. Following this approach alone will not help us achieve the first 90, particularly among key populations. A lot of key populations don't consider their sexual partners as partners. A lot of them have sex with individuals that they don't even know their names. They don't even have their contacts. So using traditional index testing, you will never be able to get their contacts from these individuals. And that is why we're promoting a risk network referral approach, which means casting a broader net. So if you have a PLHIV as a key population individuals, ensuring you get the contacts, yes, traditional index testing, but also giving them an opportunity to refer, giving them an opportunity to link other people within their social network or sexual network using referral slips, using coupons, doing that online, and bringing more people into the fold, thereby helping to achieve that first 90. Just some differences between our test and our treat and test approach and traditional index testing. You will see it prioritizes the personal needs of PLHIVs. It supports referral to a broader set of network members with similar risk, not just direct contact or sexual contact. It also helps offer self-led options for confidential or anonymous referrals, and it also provides an opportunity to link individuals who test HIV negative to prevention services, including PrEP. Second 90. Linkages has promoted the peer navigation plus approach, which goes beyond just linking people to treatment, but also ensuring their peer navigators who are members of the key population community, who are also living with HIV, also support PLHIVs within their social network and within their sexual network, ensuring linkage to prevention for those who may be HIV negative, ensuring treatment reminders, adherence support, viral load access, etc., including providing psychosocial support to those who may need it. So thinking beyond just peer navigators, linking people to services, to supporting them across the treatment part of the cascade and ensure retention within our treatment programs. The other thing that is very important that we're doing currently is ensuring that our KP programs are not left out when you talk about MMSD or Tier 2 transition. Remembering the fact that a lot of individuals who are HIV positive who are on treatment are lost to follow up because of side effects. And we now have a regimen that is very, very conducive. So I think they shouldn't be left out in terms of TLD and MMS. Now, for the third 90, there are different kind of strategies that we're currently promoting across Africa just to improve access of KPs living with HIV to viral load, including availability of sample collection methodologies at drop-in centers. Even if the tests will not be done at drop-in centers, but let KPs who are accessing services at community sites be able to have their specimen collected and transported to the lab, and the result comes back using the same approach. Prep for key populations. I included this because a lot of countries right now in Africa where we're implementing, we've not been able to move forward with the agenda of PrEP because of a lot of issues, policies, and I'm sure most of you are very familiar with that. So how do we ensure that as we promote PrEP, we're not just promoting PrEP for key populations, but we're promoting PrEP for all individuals who are at risk of HIV acquisition and focusing more on behaviors of individuals rather than categorizing them as populations. We've seen across multiple countries that we're only able to find the low-hanging fruits. A lot of KPs are not comfortable coming forward to access services due to all the issues that we're aware of. The legal environment, stigma and discrimination. We're beginning to now find people using some of our online approaches. I'm going to give you an example from Kenya. And I think this is very, very significant to us. If you look at it, on the left, the bar chart is showing that many of the key populations many of the individuals we are reaching online, many of them do not identify as KP, but more than 75% of them report at least one risk behavior in the last 6 months. This is Kenya, and this is just data within a month. Now, if you look at the right, you are seeing that within the last 6 months, about 21% of them actually said they've had multiple sexual partners. So which means if we continue to focus on providing services through physical spaces, a lot of people will never be reached with services. Now, look at the next slide. 2 things I'm going to show here. The first one is that the HIV testing history, most of the individuals that were reached online said they've never tested before. Never tested. Look at the second one. It's showing that of the individuals that were reached, about 158 of them were HIV positive already. Now look at it. Almost half of these individuals require one support or the other with their treatment, either non-adherent or positive, not on treatment, or loss of follow-up. So which means going online provides another opportunity to reach newer people, a different category of people that we're currently not reaching using traditional approaches. Now, do not forget structural interventions. For KPs, these structural interventions are actually more important than HIV testing. Without addressing violence, without addressing stigma and discrimination, particularly within healthcare settings, without investing in the safety and security of KPs, including KP implementers, we will not be able to achieve our goal. Just to give you an example, that across multiple countries now, we're beginning to see full cascades. Gone are those days where for key populations, you only see prevention cascade, testing, and then linkage to treatment. We're beginning to see in a lot of countries, people are tested, those who are positive are linked to HIV treatment, and those who are linked to HIV treatment are beginning to access viral load testing. And I'm going to skip this. Burundi, just to show that a lot of our key populations now are also accessing viral load testing, and we're beginning to have that data as well. Now, in terms of conclusion, because I've run out of time, why achieving the 90-90-90 or the 95-95-95 by 2030 is realistic, and I strongly believe in that. The journey to the end will remain very, very far, and it will remain unrealistic unless we fully engage the key population individuals. Remember, nothing about us without us. There's nothing you can do for key populations without fully engaging key populations. There's some resources, but just to close by thanking all our strategic partners and thanking PEPFAR USAID and thanking interest organizers for the opportunity. Thank you very much.